More than half of the patients that come into the emergency room with chest pain end up having a non-cardiac cause. But here's the challenge for urgent care providers. You cannot rule out ACS in urgent care because when you're evaluating chest pain, you're not trying to prove it's a heart attack, you're just trying to make sure you're not missing one. Let's talk about it. Your MP pal here. Welcome to Lessons from the Tracks. Today we're going to be talking about chest pain. All right, you've been working for several years now, primary care, urgent care, ER. You're going to see a lot of complaints of chest pain, okay? And the variations of it is definitely going to be widely ranged from a younger person to, somebody in their 50s, 60s, 70s. So how you typically will kind of start it off. Now, chest pain is one of those chief complaints that immediately puts everyone on high alert. So I've worked numerous places over the years. I'm nearing a decade in practice, but I've worked in all settings, various urgent cares. Even now, I work for one company, but I work at different locations. So every clinic operates differently, but it's usually the same response. Over the years, I've just had a lot of time just to recognize patterns, okay? So usually how it starts is, the patient comes in and then the front desk person, runs to the back. Hey, this patient is having chest pain, right? Automatically high alert. Now, some companies actually have a protocol where you're supposed to just bring the patient straight to the back, their triage room or whatever they call it, and wherever you work. So when that happens, I usually like to just lay eyes on the patient, okay? Not go up there and talk to them, but if I can at least see them, because usually the front area is going to be pretty open. So if you can just kind of peek your head and look at them, just lay eyes on them. Or if there's a door, if you can just somehow get a glance at them, okay? If they're sitting there calmly filling out paperwork, that immediately lets me know, okay, we have time. Now that's different, if somebody is, they're hovering over the desk and they seem to be struggling, I get those back quickly, okay? But the majority of them that I have taken care of usually have time. So if I see them calmly writing, I'll just tell them, hey, just let them fill out their paperwork. We'll get them back, get their vitals and do an EKG, and then I'll be in there. That way you have information, when you walk into the room. Now again, with chest pain, there's all kind of varieties. I know just over the years, I've seen a lot of younger patients with it. So, somebody 19, 20, how that goes. They have chest pain at home. What's the first thing that they do? They start Googling and I have this. I have this one too. And then, bam, they're in front of you, okay? So now you're going through that process. So for a chest pain evaluation, I already prepared to be in the room, a little bit longer. Like I already know I'm gonna have to talk to that patient more because a lot of it is just, reassurance and things like that. So you may have that young person or another common person that you'll see is just like a guy that's like 37 years old, just normal looking guy, not out of shape, not too fit either, just come in and just very vague with his symptoms, something like, it's kind of hard to explain, it's just like right here in the center. How long has it been going on, sir? About a month, and it's just right here, it's not like a pain, it's just like I just feel it. And, they always wait a month to come in, right? Like, why do you wait so long? So anyway, so that's something that is very common, okay? Now, here is when I do get concerned, okay? Because most of the ones I see in the urgent care, they usually get discharged. They usually walk out of it without me having to call EMS or send them to the ER, okay? But when I do get concerned, it's typically when they have additional symptoms such as dizziness, shortness of breath, blurred vision, that kind of stuff there, then I'm like, okay, you need to go to the hospital, okay? Or if they have abnormal vital signs. Now, of course, chest pain does cause some anxiety, okay? So blood pressure, 150, 160, okay. I usually, we're gonna check it multiple times, because usually that's their initial one and they're already freaking out before they get there. So usually I will have my tech recheck it, just give them a little bit, let them calm down. Even like letting them wait to fill out the paperwork, that's still kind of lowering their anxiety sometimes. Now, sometimes you just have that really anxious patient that nothing matters, okay? But sometimes just using time as an intervention is actually very helpful. So, but yeah, I mean, if they're tachycardic with it, 130, 140, or if you recheck it and it's like 170, 180, and they're having chest pain in that moment, they are usually gonna be referred to the ER, okay? So, because we all know that the true way to rule out ACS is to get what we call a cardiac workup. So typically it's gonna be a CMP, CBC, troponins, and EKG, of course, and a chest x-ray. When I worked in the ER, that was pretty much the cardiac workup. Back in the day, 2014-ish, somewhere around there, they used to do the whole cardiac enzymes, CK, CMB, it was like you had to wait like 6 hours. You had to have a three tests that you have to do. But now they have these high sensitivity troponins that are they're quicker. You don't need the full panel. So usually you do the first one and then you have to wait like anywhere between 1 to 3 hours depending on where you go. Again, we can't do that in urgent care, okay? So I usually spend a lot more time just talking to that patient, kind of talking them off the ledge, going through the history and things like that. And even if it's a little high, the blood pressure, you can still recheck it after the conversation. A lot of times it's just magically better, okay? So we know the EKG alone does not rule that out, okay? So just remember, we're not trying to prove it's a heart attack. We're just trying to make sure that we're not missing anything, okay? So always get the EKG first. I usually like to have that done. But also just spend a lot more time just kind of talking to them. Now, sometimes you may have a very aggressive patient or they come in there, I want to know and make sure I'm not having a heart attack. That's actually very simple for me because we can't do that here. I already know I can't do that. So I just usually just, hit the patients with the facts, okay? And most of the time, patients will respond to what you say. Like I had a lady last week and she had a history of hypertension, had taken her medication, having chest pain, and she was like, yeah, short of breath, and her blood pressure was like 170, 180, and we rechecked it, and it was a no-brainer. I was like, you need to go to the hospital. I was like, with your history, your symptoms, your blood pressure's high, like this is no question, okay? And I always like to blame it on the setting, right? Because some patients will kind of look at you like you're limited. Oh, you don't know what this is? It's like, no. This is an urgent care. We have very limited resources here, and I can't do all the testing that needs to be done in order to tell you that this is not that. So even if you haven't worked in the ER, I always just like to paint a picture. I mean, I do have an ER background, but I just tell them if it's something really concerning, like, hey, if we were in the ER right now, this is what I would do. I would get labs, I would get a chest x-ray, and I would get an EKG for sure, and maybe a cardiology referral. So that way you kind of let them know, like, this is what probably should be done, depending on the situation, okay? Now, one more thing that I do, if I can safely discharge them, is always put a cardiology referral, okay? It makes them feel better, okay? Even if it's fine, they're young, I always do it because even though you may not have found out the cause of the chest pain, at least you did something. They can say like, oh, you didn't do anything. Yes, you got an evaluation. You checked their vitals. You did an EKG. Sometimes chest x-ray, depending on if they're having shortness of breath with it, I'll just do it just to kind of cover the bases. Because again, a lot of these patients are kind of walkie-talkie and they don't necessarily need an ER referral, okay? So, we're not ruling out a heart attack. We're just making sure we're not missing one. And always do cardiology referral, okay? All right, because remember, clinical confidence comes from a repetition, okay? And recognizing patterns. So just something that comes with time. All right, your MP Pal here. Practice boldly.